is malabsorption, important topic of GI tract. See here, in the beginning, I'll start with some basic concept, and then later on we'll go to the diseases. The most important disease which we are going to talk here is celiac disease. Celiac disease, autoimmune disease which leads to malabsorption and chronic diarrhea. Now, the first, first few slides would be about the causes of malabsorption. What are the disease? Okay, what are the disease which cause malabsorption? Now, see there, this is a bit of difficult question because a lot of conditions are there. Let's start with gastric disease or problems from the stomach. So gastric diseases, they are pernicious anemia, atrophic gastritis, and gastric resection. All of these can lead to malabsorption. Just now, before this topic, we talked about the role of stomach regarding absorption and digestion of the food. So, pancreatic disorders. Pancreatic disorders or diseases are other types of condition which leads to malabsorption. Chronic pancreatitis, those pancreatic enzyme cannot come into the second part of the duodenum. Cystic fibrosis, it also leads to chronic pancreatitis, okay, because pancreas is one of the gland which is very badly damaged by cystic fibrosis. Others are lung, okay, other organ I should say are lung and liver. So again, the exocrine part of the pancreas is suffering because the pancreatic juice is not flowing there, which leads to malabsorption. Pancreatic tumor, they can destroy the pancreas. Congenital pancreatic enzyme deficiency, congenital absence of the pancreatic enzyme. So it is very easy for us to understand. Pancreas plays a big role in the digestion of the food. Okay. Pancreas plays a big role in digestion of the food. If something wrong happens in the pancreas, then there is malabsorption. Now, third heading is the liver disease, cirrhosis of the liver, primary biliary cirrhosis, and sclerosing cholangitis. Now, we need bile. We need bile for the fat absorption and fat soluble vitamin absorption. So if liver diseases are there like this, and if there is a decreased production of the bile, or if there is a disturbance in the flow of bile towards the intestine, then fat cannot be absorbed. So fat malabsorption can occur easily. So this is the explanation. So other conditions are intestinal diseases like celiac disease, okay, celiac disease, tropical sprue, Crohn's disease, amyloidosis, bacterial overgrowth syndrome, eosinophilic gastroenteritis, ileal resection, intestinal infection, Whipple's disease, and intestinal lymphoma. Now there are multiple mechanisms by which intestinal diseases leads to malabsorption. It depends on which disease we are talking about. So in celiac disease and tropical sprue, there is damage to the villi, so the absorption area is having problem. In Crohn's disease, similar type of situation, the terminal part of the ileum, or in fact any part of the GI tract may be affected or damaged. Okay, so amyloidosis is a deposition of abnormal protein there, so it will again disturb the absorption process. Bacterial overgrowth syndrome, these bacteria will degrade the food particle, so they will hamper the absorption and digestion process. Okay, ileal resection, the major part of the ileum from where food is getting absorbed is resected because of some diseases like ischemic bowel, one perfect example. Okay, so other things are same, so there are multiple mechanisms. Now, lymphatic disease, one of the important example is intestinal lymphangiectasia. Those lymph channels are dilated, okay, so they hamper the absorption of the food, especially fat, because fat is directly absorbed into the lymph. neuroendocrine tumors, carcinoid syndrome, and Zollinger-Ellison syndrome. In carcinoid syndrome, there is chronic diarrhea as a result of serotonin, and in Zollinger-Ellison syndrome, there is inactivation of the enzyme which are coming from the pancreas. Remember this, inactivation of the enzyme which are coming from the pancreas, because the high level of acid or high amount of acid which is secreted in the stomach cannot be neutralized, and this acid will inactivate the enzyme in second part of the duodenum, resulting in malabsorption and diarrhea. Cardiac causes are heart failure and constrictive pericarditis. Now, in both of these situations, there is chronic edema of the bowel. Okay. Chronic edema of the bowel. Now, if edema of the bowel occurs, then again it hampers the absorption process. Okay. These are the cardiac causes. Now, others are endocrine causes or endocrine disease like Addison's disease, diabetes, and hyperthyroidism. Addison's disease, diabetes, and hyperthyroidism. Now, Addison's disease is known as hypoadrenalism. Diabetes can lead to neuropathy, and hyperthyroidism can lead to chronic diarrhea with increased peristaltic movement. Now, some systemic disease can also lead to the same type of problem, like mixed connective tissue disorder, scleroderma, okay, also known as systemic sclerosis, and even SLE. So there are so many causes for malabsorption. This is relatively a big topic. If a patient comes to hospital with chronic diarrhea, and if you believe this is a case of malabsorption, now you have a tough job in your hand. You need to take a very good history, okay, do a good investigation to confirm the diagnosis. Now let's talk about normal physiology here, how our food is getting digested and absorbed. Now we are talking about three main macromolecule here: carbohydrate, protein, and fat. Now these are the different way of normal digestion and absorption. First is a mechanical mixing of the food, which happens in stomach. This is the main function of stomach here. Enzyme and bile salt production is the second one. These enzymes are mainly produced by pancreas, and bile salts and bile acids are produced by liver. Mucosal function has to be intact, and this is the job of intestine. In the intestine, mucosa is there, and the innermost layer of the mucosa is epithelium. So those epithelial cells has to be normal. There has to be good blood supply for the normal, okay, digestion and absorption. Ischemic bowel cannot do all these functions. Intestine has to move well. That is called normal peristaltic movement, and that is contributed by vagus nerve. Commensal gut flora. Now this commensal gut flora also helps, because if some bigger food particles are still there, they can degrade it, and at the same time they can synthesize some of the vitamins. Okay, they can synthesize some of the vitamins there. Now which vitamins can be synthesized by commensal gut flora? Yes, I want some answer. Yes, guys.
Vitamin K.
Vitamin K.
Very good. One is vitamin K. Excellent. Any other?
Biotin, sir.
Biotin. Very nice. Biotin. One more.
Folic acid.
Okay. Is it folic acid? No. It's vitamin B12. Okay. Vitamin B12. Not folic acid. Folic acid is not synthesized by these gut flora. So vitamin K, biotin, which is also known as vitamin B7, and vitamin B12. These are the three important vitamins which are synthesized by gut flora. They can be asked in MCQ exam. Please have a note. Now we have a bit of time, so let's talk about fat digestion and absorption as the first of all those three macromolecules. Now follow here. Okay, I am going to explain step by step. Now the main component of fat which we take in our diet is triglyceride. Okay, we call it TG, triglyceride. Now this triglyceride is present in the GI tract now, okay, in the stomach, and from stomach it will go to the second part of the duodenum. Now pancreas, okay, pancreas is releasing lipase enzyme. Now there are some local gut hormone which are released after the food reaches the duodenum from stomach. Okay, these are called local gut hormone like CCK and secretin, cholecystokinin and secretin. Now they stimulate the pancreas to release all those different enzymes. Now you just know this much now. So lipase is one of the main enzyme which digest the fat. Lipase, okay. Lipid breaking enzyme is called lipase. Now this triglyceride will be broken into 2 fatty acid and 1 monoglyceride. Now what is happening here? Liver is secreting bile salt or bile, you can say. With the help of this bile, okay, emulsification process occur which is called micelle formation. After emulsification, micelle is formed. These micelles are some particle. Now these micelles will be absorbed into the intestinal epithelial cell. Okay, remember these micelles are having some components of triglyceride. So inside the intestinal epithelial cell, one important lipoprotein is synthesized which is called chylomicron. It is a type of lipoprotein which is synthesized by epithelial cell. Now this chylomicron's function is, it is a carrier of fat. In this case it is carrying triglyceride. Now all these fatty acid and monoglyceride, when they enter into the intestinal cell, they again combine together and form TG or triglyceride. Okay, now chylomicron will travel into the blood. This is called distribution. So this is all about fat digestion and absorption from the GI tract. Okay, let's restart. Before the break, we're talking about the causes of malabsorption and how fat is getting absorbed. Now let's proceed further. Let's talk about how carbohydrate and proteins are digested and absorbed, and then we move on to the different other parts of malabsorption. Now protein is a bigger particle or bigger substance, I should say. It would be degraded into oligopeptide, okay, and then amino acid. That amino acid is the smallest molecule in protein. So it is absorbed as amino acid, and that is done by different enzymes, okay, which are known as protease. So see there, protein is degraded into oligopeptides by pepsin or pancreatic protease, and oligopeptide into amino acid by mucosal peptidases. This mucosal peptidase is present in the brush border of villi. This is important point you need to remember. That's why if those villi are damaged, or because of chronic diarrhea or even acute diarrhea, okay, those villi may be damaged and they will regenerate later. Then for a certain period of time, these proteins and sugar cannot be digested. Now what about carbohydrate? The carbohydrate will be broken into oligosaccharide, okay, and then into the sugar. This sugar means monosaccharide, okay, monosaccharide. The most important monosaccharide is glucose. So you can also remember it is absorbed in the form of glucose. So salivary amylase and pancreatic amylase are the important one. Pancreatic amylase is much more important than salivary amylase for the digestion, and there is mucosal disaccharidase which is present in the brush border of villi, and these are also important terminal enzyme which will break down oligosaccharide into monosaccharide, and they are absorbed. Now let's talk about what are the mechanisms of fat malabsorption, carbohydrate malabsorption, and protein malabsorption. Now so many of the points would be overlapped here. Okay, Related to the mechanisms of fat malabsorption, pancreatic insufficiency or pancreatic failure, mainly the exocrine part of pancreas. One of the common causes is cystic fibrosis, bile acid deficiency, maybe liver disease or obstruction of the bile flow, small intestinal bacterial overgrowth, they will degrade, okay, all those contents of the fat. Loss of absorptive surface area, okay, if we have done resection of the bowel, that should be done after ischemia. Defective enterocyte function, okay, some damage to those epithelial cells of the mucosa, and lymphatic disorders like lymphangiectasia and even congestive cardiac failure. You can take that example here as well. So these are the mechanisms of fat malabsorption. What about mechanisms of carbohydrate malabsorption now? Selective disaccharidase deficiency, okay, it is present in the villi. Disruption of brush border or enterocyte function, see there, problem with epithelium. Loss of mucosal surface area, either due to celiac disease because of loss of villi or because of gut resection. And pancreatic insufficiency again. Where is the amylase enzyme if pancreas is not functioning? Without amylase enzyme, carbohydrate cannot be digested and absorbed. Now, what are the mechanisms of protein malabsorption then? See there, most of the functions are same. Sorry, mechanisms are same. Pancreatic insufficiency again, no trypsin, no chymotrypsin, no proteases. Disorders with impaired enterocyte function, again celiac disease, okay, uh, all those other disorders, even acute diarrhea sometimes. Disorders with decreased absorptive surface, same conditions which we have listed before. And protein losing enteropathy, these are the mechanisms of protein malabsorption. So these are just the pathophysiological mechanism. Now, after going through all these physiology, let's talk about how the patient present to the hospital. What are the clinical features or clinical presentation? The most important one is diarrhea. Now, the reason for diarrhea here is because of malabsorption. Food is not absorbed, and when it is not absorbed, it is going to the distal part of the intestine, then enters the colon, okay, and during its passage there are lots of osmotically active substances present there. They will draw fluid inside the lumen of the bowel, okay, and that is the main cause of diarrhea. This diarrhea is a chronic type of diarrhea in case of malabsorption. Steatorrhea is a fat malabsorption now. The fat is passed in the stool. Steatorrhea. Some of the important points regarding steatorrhea are that stool looks bulky, okay, bulky or increase in volume, number one. Number two, very foul smelling. Number three, it is sticky and greasy because of the presence of fat. This is exactly how you take the history in case of steatorrhea. You can't ask your patient, do you have steatorrhea, isn't it? That is a very stupid type of question because patient don't understand this medical term. So you need to ask in some other way, like exactly those way which I'm talking now. Weight loss, very important feature of malabsorption because they suffer from malnutrition because of loss of the nutrients in the stool. Bloating, distension, gas, and borborygmy are important feature. Now, what is the mechanism for this? It's very simple. All those food particles which are not getting absorbed in the small intestine will go distally now, and the gut flora which are present there will act on them and they will degrade those food particles. During that process, a lot of gases will be formed. These gases are responsible for all these features like bloating, distension, even abdominal pain, and excessive movement, excessive sound is heard from the abdomen, that is called borborygmy. Borborygmy. You can also call it wind. Anorexia or hyperphagia. Mostly they suffer from anorexia, but some other patient may suffer from hyperphagia. They eat a lot, but actually all of that is a waste, isn't it? Because that is not getting digested and absorbed. Nausea, vomiting can occur, abdominal discomfort because of gases, muscle atrophy because of malnutrition, edema because of hypoproteinemia, and signs and symptoms of specific vitamin deficiency. Now, vitamin B, vitamin C, all those fat soluble vitamins, all of them can be deficient if this disease is chronic. Now, what about the important history and physical exam you are going to do? Now, see there. So, we need to take some important history like prior GI surgery, whether gastrectomy was done before, whether intestinal resection was done before, whether cholecystectomy was done before, any type of surgery done before, you need to take the history and note it. History of chronic pancreatitis. Now, this is a bit of indirect question you need to ask, like history of alcoholism, history of gallstone disorder in the past, because these are the one which can lead to chronic pancreatitis and then loss of those enzyme which leads to malabsorption. History of liver and GI disorder. History of liver and GI disorder, one of the important question you need to ask is history of jaundice in the past. Jaundice is one of the important symptom of liver disease. And GI disorder, there are so many like diarrhea, constipation, isn't it? Pain in the past. History of connective tissue disease and diabetes, you need to ask specifically because many people they know because doctor has told them the diagnosis. So if they remember, that is quite good for you. History of radiation therapy, which can damage those villi and intestinal epithelium. Use of alcohol or any other drugs, take a history and record them. History of chronic sinus or respiratory infection. Now there is a good correlation with cystic fibrosis here, because cystic fibrosis is a disease, which can damage this. Okay guys, there was a bit of connection problem. Now I'm back online here. So we're talking about a different history in case of malabsorption. So I was talking about chronic sinus or respiratory infection here. That is strongly connected with cystic fibrosis, because this is a disease which is damaging a different exocrine glands or different glands of our body. You can remember like that, like lungs. There are multiple glands in our airway, so they are badly damaged. Pancreas is another gland, and even sinuses are a part of that. Or you can explain in another way. Cystic fibrosis is associated with bronchiectasis, and all those things. Recent travel history is important, especially history of chronic giardiasis in those endemic area. If a travel history is there in the endemic area, you can easily think about chronic giardiasis. Chronic giardiasis is an important cause of malabsorption. Timing of onset is important. Bowel habit and stool characters, always an important question here. Always. Bowel habit means, is there constipation, is there diarrhea, how many times the stool has been passed, what is the nature of the stool, every questions you need to ask. Associated GI and systemic complaint, associated GI and systemic complaint you need to ask. Systemic complaint are mainly present in connective tissue disorders because multiple organs are affected here. Evidence of malnutrition or micronutrient deficiencies and exam, like in case of vitamin A deficiency, they have night blindness, right? Night blindness, also known as xerophthalmia. In case of vitamin B deficiency, so many types of vitamin B are there. So accordingly, different signs and symptoms may be there. In vitamin C, scurvy, it is called scurvy, especially joints are involved there, right? In vitamin D, in case of children, rickets, in adults, osteomalacia, like that, the questions can be asked. Now, let's talk about what are the tests you like to do in a case of malabsorption. What are those tests you like to do? See here, blood test, simple type of blood test should be done like CBC, what is the total protein level, what is the total albumin level, Okay, all those things should be done. What are the electrolytes? Okay, it depends on the situation. Fecal fat determination, is it the case of steatorrhea or not? Okay, that will confirm it. Imaging study like ultrasound and all other types of imaging study, radiological study we say, endoscopy with biopsy and aspiration to confirm the diagnosis, and even breath test. Okay, let's analyze them one after other. Now see here, these are the screening tests in case of malabsorption. Now these are the blood tests: CBC, complete blood count, sodium, potassium, magnesium, phosphate, and calcium. Okay, albumin as well as protein. If you suspect vitamin deficiency, go for the vitamin level, B12, folic acid, iron level, that will confirm whether they are deficient or not. Go for liver function test if you suspect steatorrhea is there, because we need to make sure liver is functioning well, liver is producing enough bile. And then a PT, INR, and cholesterol. PT, INR, and cholesterol. Now this PT and INR, prothrombin time and international normalized ratio, this is again associated with vitamin K and liver function, because vitamin K is responsible for activation of certain vitamin K dependent factors like 2, 7, 9, and 10. And in chronic liver disease, these factors, okay, will not be there, or these factors will not be active. Stool test should be done, inspection and routine examination of the stool, whether there is occult blood present or not, and what type of fat is present in the stool. Okay, the qualitative fat. Now there is one more test which we do is fecal fat determination quantitatively. Okay, then these are two types of fecal fat test. Okay, let me highlight a little bit here: quantitative and qualitative. The qualitative means which type of fat is getting lost in the stool. This is qualitative. Quantitative means how much fat, okay, how much fat is getting lost. So this quantitative determination of fat in the fecal matter is the gold standard to diagnose maldigestion or malabsorption. And for this we collect 72-hour, okay, fat from the stool, or you can also say 72-hour collection of stool has to be done, and then analyze that for how much fat is present there. That is the way. Now see here, normally less than 7 gram per day, but if it is more than that without diarrhea, and even more than 14 gram per day with diarrhea, it suggests steatorrhea. So let me highlight this again. We collect 72-hour stool, then analyze how much fat is present there. If fat is present for more than 7 gram per day without diarrhea, or more than 14 gram per day with diarrhea, it suggests steatorrhea. But there are certain limitations of this, because you need to collect stool for 3 days, and this is a quite a cumbersome method. Okay, there are certain other way which determines the qualitative fat also, like which fat is present there, and that can be done by certain staining and counting the size of fat as well as droplets. This is not a very important point. Now, what about test for carbohydrate malabsorption? Now, one of the important test here is called hydrogen breath test. Now, how we do that? We give 50 gram of lactose orally, and then analyze how much hydrogen is present in the breath every hour for 4 hours. So 50 gram of lactose is given orally, and after that the breath hydrogen is analyzed every hour for 4 hours. Normally less than 10 parts per million, ppm is parts per million, above the baseline in normal individual. Okay, so less than 10 parts per million above baseline in normal individual. Now what is happening here in case of carbohydrate malabsorption? The carbohydrate is not getting absorbed. Okay, so it is collected there in our intestine. all those bacteria, they will degrade this carbohydrate and then liberate gases. Hydrogen is one of them. That hydrogen gas is absorbed in the circulation, okay, and through the lung, okay, through the lung it is excreted. So we are measuring that hydrogen ion in this hydrogen gas, I should say, in this test. This is called hydrogen breath test. Another type of test is lactose tolerance test. Now this is even more important question, especially in pediatrics. Now listen carefully. After an episode of diarrhea, viral diarrhea is very common in pediatric age group like rotavirus. Most of the children, okay, they cannot digest milk for certain duration. Now what may be the reason for this? Probably that disaccharidase enzyme, which is a lactase enzyme, right, which may be present on the brush border of villi, that is gone because of the damage to those brush border or villi, and it will take time for them to regenerate or recover. So till that period, now lactose is a type of disaccharide, it cannot be digested. So we need to wait for certain duration. This is the perfect explanation for lactose tolerance test. So you just, if you suspect that, just give a lactose containing food like milk and see whether it can be digested properly or not. If it is not digested, that person will develop diarrhea. Okay, that is quite important one. Another is direct assay of mono as well as disaccharidase. Another type of test we can do is direct pancreatic function test. Now, how to do that? Okay, let's not go into the detail here. I'm just going to give you some principle. Okay, this pancreatic function test means we are going to measure that particular enzyme which are released by exocrine part of the pancreas. And remember, there are two important gut hormone, local gut hormone, which are stimulating pancreas for the release of this enzyme. These are secretin or cholecystokinin. Secretin or cholecystokinin. So you stimulate pancreas by this and analyze how much enzymes are released. Another type of investigation in case of malabsorption is small bowel culture. Now this is done to know what is the the concentration of bacterial overgrowth there. If you suspect bacterial overgrowth is the cause of malabsorption in this case, then you go for this type of investigation. And the abnormal report will be analyzed as more than 10 to the power 5 colony forming unit per ml. This is called colony forming unit. The same type of description we used to do in case of urine culture as well. Okay, colony forming unit, similar type of things. Now this is not routinely done because this is an invasive type of method. Okay, and there are many bacteria in our GI tract which cannot be grown in the culture. Okay, so all these practical problems are there, but this is one of the way. What are the imaging study or imaging technique we use to diagnose different types of or causes of malabsorption? Barium contrast small bowel series can be done. Okay, this is the barium contrast X-ray of small bowel. CT and MRI can be done if you suspect some tumors, especially tumors can be very easily picked by CT as well as MRI. Enteroscopy, this is the endoscopic examination of the bowel. And ERCP, endoscopic retrograde cholangiopancreatography. Endoscopic retrograde cholangiopancreatography. These are done for either pancreatic diseases or common bile duct diseases. Okay. Now, with this, information, which are actually a bit of basic things here, let's enter into the disease proper, and that is celiac disease. If any question comes from this topic, the questions will come from this celiac disease. Now, let's introduce what is celiac disease for you. This is an immunologically mediated inflammatory disorder of the small bowel. Let me underline the important points. This is immunologically mediated disorder, first thing, and it damages small bowel, which occurs in genetically susceptible individual, and this disease, okay, results from intolerance to gluten protein. That's why it is also known as gluten sensitive enteropathy. Gluten sensitive enteropathy. Now let me make it easy for you. Now what is celiac disease? There are certain individuals in this world which are, okay, sensitive to certain protein in their diet, and that protein is called gluten, gluten containing food. Now if they take that type of food, okay, they are already genetically predisposed to those type of food or protein. So what will happen? That protein will cause severe immunological reaction inside the intestine, in the lumen of the intestine, okay, and that can result in damage or destruction of the villi. Now when villi are damaged or destroyed, the food cannot be absorbed properly. This is called celiac disease. So there are certain points we need for the diagnosis. Okay, one, they are genetically susceptible individual. All of us will not develop celiac disease. Remember, we can eat anything, whatever we want. We don't develop any diarrhea because we are not genetically susceptible regarding that. Second point, that person has to take gluten containing food. And third, immunological reaction should occur, then only celiac disease can happen. This is the way to remember. Now it leads to severe type of malabsorption. Okay, it leads to severe type of malabsorption, and then this disease is prevalent worldwide, but quite common with Caucasian population. This is a common disease worldwide. It is also known as celiac sprue. Now, what is the pathophysiology of celiac disease? Many of the point just now I told you, so let's discuss them in a little bit detail. Now there are various theories, okay, which tells us what are the way by which this disease occur. Okay, so let's repeat once again a little bit point here. Genetically susceptible individual has to be there. Now what are those genes? You may be wondering, what are those genes which should be present? Now see, look at the name of the genes here. HLA-DQ2 allele, okay, or HLA-DQ8 allele. These are important. If somebody is already carrying them, then they have high chance of having a celiac disease. There should be some precipitating factor as well, okay, precipitating factor or aggravating factor we say, and these are surgery, pregnancy, any infection in the body, as well as emotional stress. So they are just called triggering factor. The person is already having gene inside them. The person should take gluten containing food, but still for that immunological reaction to happen, okay, these are the triggering factor. Now let's talk what type of reaction is going on inside the bowel now. So the person has taken the gluten containing food. See this, okay, gluten in the diet. Now it is taken up by epithelial cells of the small intestine, mainly jejunum and ileum. Now inside this epithelial cell, this gluten is a bigger type of protein. So it is deamidated to gliadin. This gliadin is a small type of protein by tissue transglutaminase enzyme. This is a very important name here because there are autoantibody which are produced against this particular enzyme, and we can use that autoantibody for the diagnosis of celiac disease. See, the name of the enzyme is tissue transglutaminase. So gliadin is formed. Now this gliadin is taken up by HLA-DQ2, okay, with the help of APC. This APC means antigen presenting cells. Okay, and these HLA genes are already present in the patient. Okay, so if you go back to your immunology, you will understand it very easily. This antigen presenting cell, with the help of MHC2 molecule, okay, will present this antigen to the helper T cell. So just like MHC type 2 molecule, in this case it is HLA-DQ2. Now this is very easy for you to understand. After that, T helper cell will become activated and differentiate into T helper cell 1. This T helper cell 1 will produce different cytokine. Now, look at the name of the cytokine here: interleukin 1, interferon gamma, and tumor necrosis factor alpha. Now this cytokine will do a lot of damage there. They will attract other lymphocytes. Okay, they will activate other lymphocytes. At the same time, okay, crypt hyperplasia will be there. There are a lot of glands in the intestine, which is known as crypt of Leverkusen or intestinal gland. Now because of the constant stimulation, these glands will become increasing number, and they start to function also in an increased amount, and there will be most important point known as villous atrophy because of severe inflammation. So this is the pathophysiology of celiac disease. Now look at this picture here. This is the normal bowel, okay? Normal bowel, and another one is celiac disease. Normal bowel and celiac disease. Now you can see the clear-cut difference. Normally these are called villi. These villi are finger-like projection or leaf-like projection from the epithelium, and these in between are called crypts of Leverkusen, intestinal gland, you can say. In celiac disease, where are those finger-like projection? Where are those leaf-like, projection from the surface? Okay, it's looking very flat. Now food cannot be absorbed because food getting absorbed from these villi. Okay, this is the major problem in celiac disease. Now after this, now it's very easy for us to understand clinical feature. Now what are the clinical feature and what are the common associations of celiac disease? Now, celiac disease can present at any age. Now, it all depends on from when we introduce that gluten containing food. Okay. Now the common gluten containing food, I'm sure you know this from the pathology lecture or even before that, right? What are those common gluten containing food? Right? Wheat.
Barley
Okay. Yes, please. What are those?
and barley.
Very good. Yes.
Barley.
Absolutely. Wheat, okay, rye and barley. Wheat, rye and barley. These are the important one. So if we give certain food which are having these, then there will be celiac disease. Now, in older children, because of this chronic malabsorption and diarrhea, they will have delayed growth. And in case of infancy, because of diarrhea and malabsorption, they don't gain weight. This is called failure to thrive. This failure to thrive is a very important term during infancy. Okay. Now, what happens in adult then? Now, in adult, the peak onset occurs nearly at 5th decade, but they can suffer from this disorder anytime. It all depends on the exposure to that food. This is autoimmune or immunological disease, so females are more commonly affected than the male. And it is estimated that 80% of the cases remain undiagnosed. Probably the reason for this is they have minimal type of symptoms or complaint. And just think about it, most of us have some amount of abdominal complaint most of the time, some amount, sometimes pain here and there, some wind formation here and there, and we ignore the situation, we ignore. So same concept here in celiac disease also, many of them are having very mild type of symptoms, so they never go to the hospital, so they are not diagnosed. But in other 20% of the cases, okay, severe manifestation may occur, which is called florid type of malabsorption, okay, which leads to steatorrhea. Steatorrhea is presence of fat in the stool. They look very tired, they lose a lot of weight, okay, they have multiple vitamin deficiency, and they are suffering from anemia as well. And this anemia is mostly iron deficiency anemia, but at the same time a vitamin B12 deficiency anemia or folic acid deficiency anemia can also occur. Now, oral ulceration, dyspepsia and bloating are other features. Oral ulceration can be very easily explained by vitamin deficiency. Remember, vitamin B2 and B3, if they are deficient, usually there is oral ulceration, and ulcer form also around the angle of the mouth. Dyspepsia and bloating are common symptoms of indigestion and malabsorption. Very common term, dyspepsia actually. We have abdominal pain, okay, you have wind formation or gas formation. All these things are combined together in dyspepsia. Okay, good morning everyone. So let's start today's class. Yesterday we were talking about celiac disease and some of the important part left behind. So let's continue. So when you talk about the clinical features of celiac disease, there are certain disease association you should know. And these disease associations are mostly other autoimmune disease in the body, okay, other type of autoimmune disease, because you know one important point, if one autoimmune disease occurs in the body, other autoimmune disease can also happen. So these are insulin dependent diabetes mellitus, a type 1 diabetes, thyroid disease like Hashimoto's thyroiditis or Graves' disease, both are autoimmune, primary biliary cirrhosis, which is also autoimmune type of disease, anti-mitochondrial antibody are very commonly found in primary biliary cirrhosis, Sjogren syndrome, a type of connective tissue disorder, pernicious anemia, okay, one of the autoimmune disease which affects stomach, antiparietal cell antibodies are present there, dermatitis herpetiformis, you are going to talk about that in this class. It is a part of celiac disease, it's a manifestation on the skin. Down syndrome, okay, common association with celiac disease, and in Down syndrome so many other features are also there. And one complication of celiac disease is enteropathy associated T-cell lymphoma, a very important question in clinical correlated exam or MCQ. Enteropathy associated T-cell lymphoma. So these are disease association of celiac disease. Now, how to diagnose? Okay, how to diagnose celiac disease? Now, diagnosis is often very difficult because most of the cases are asymptomatic. Almost 80% of the cases are asymptomatic. They don't have much clinical features to start with. And if the patient already have suspicion about celiac disease, and if they are taking gluten-free diet, then all the investigation may come negative, isn't it? These days, because of the effect of the internet, okay, because of the effect of internet, people know about their disease. They can suspect, and they can themselves, start some of this type of therapy like gluten-free diet. Then report may come negative. This is very important point. For those who have already started on a gluten-free diet, it may be necessary to perform a re-challenge with some gluten-containing food in 1 meal a day over 6 weeks before repeating the investigation. So this is called gluten challenge test, because gluten containing food has to be there in the intestine, then only that reaction can occur, and that reaction will damage the villi. Okay, so this is the important point in diagnosis. But that challenge will harm a little bit regarding the patient. Patient may suffer from diarrhea, but it doesn't last longer. After we confirm, we'll stop that gluten containing diet again. Now, what are the investigation you like to do? Let's start with hematology and biochemistry. Microcytic anemia or macrocytic anemia, both can occur. Now, microcytic anemia is because of iron deficiency anemia, which is very common in celiac disease because iron is also not going to be absorbed. Whereas macrocytic anemia is because of vitamin B12 and folic acid deficiency. So any type of nutrients are not going to be absorbed, okay, because of the damage of villi. So all these type may occur in this condition. There may be reduced level of calcium, magnesium, total protein, albumin, or even vitamin D. The same reason can be given. Now, regarding the serological test, these are diagnostic in case of celiac disease, as this is an autoimmune disease. So these are serum anti-transglutaminase antibody, serum anti-transglutaminase antibody, and anti-indomycial IgA or IgG antibody. Now, yesterday, when we talk about pathophysiology, there was an important role of tissue transglutaminase, enzyme. Now, that enzyme is attacked by immune system to develop anti-transglutaminase antibody. So this is a diagnostic, point here. IgA anti-indomycial antibody. Okay, it's the same term actually, uh, same type of antibody. They are detected by immunofluorescence study, and the sensitivity and specificity are quite high. So if we detect this particular antibody, then diagnosis is done. Okay, IgA anti-indomycial antibody is important point. Now you may be wondering why transglutaminase antibody is also known as anti-indomycial antibody, and the reason is this indomycium has tissue transglutaminase enzyme. Now, if strictly speaking, this indomycium is one of the layer, okay, one of the covering of the muscle, but this indomycium has tissue transglutaminase enzyme. That's why these terms are used interchangeably, anti-indomycial and anti-transglutaminase. Now, thyroid function test can be done to rule out hypothyroidism, because many autoimmune diseases in thyroid can occur. Even Graves' disease can be seen in this condition. These are just the association. Now, the gold standard, okay, investigation in duodenal in celiac disease is duodenal or jejunal biopsy. This is even important than those antibody detection. That's why it is known as gold standard investigation. So this is taken by endoscopy. Okay, the biopsy is taken by endoscopy in this case, and when we analyze this under the microscope, look here, there are absence of the villi, or sometimes the height of the villi are very short, means it looks flat. Okay, it looks almost flat there. Normally the villi are quite tall finger-like projections, but in this condition they are very flat and they cannot do their job now. On the other hand, there is crypt hyperplasia and loss of villous structure, which we already talked. There is increased deposition of lymphocyte. Okay, this blue dot you can see in the picture, all of these are lymphocytes. Okay, as well as plasma cells. These are called chronic inflammatory cell. So let me summarize again. The villi height will be decreased, or they may be totally flat. There is crypt hyperplasia, means these glands which are present here, like these goblet cells, would become increase in number, and there are lots of chronic inflammatory cells deposition. Now, this celiac disease is causing villous atrophy, which is known as subtotal villous atrophy. So there are so many other conditions which can also lead to subtotal villous atrophy, and those are tropical sprue, which is caused by infection. If somebody travels to those endemic areas, then they can suffer from tropical sprue. Most of the clinical features are same, except this is caused by infection. Lymphoma, This is a malignancy. AIDS enteropathy, the HIV is damaging the intestine. Giardiasis, especially the chronic type of giardiasis. Hypogammaglobulinemia, a type of immune deficiency condition where there is decreased amount of antibody level. Radiation exposure can damage those villi. Whipple's disease, caused by a bacteria known as Trophorima whippeli. It is a multi-system involvement. And Zollinger-Ellison syndrome, we have already studied that. This is a tumor in the pancreas which is releasing a lot of gastrin, and that gastrin is causing more release of HCl, and all other sign and symptom will arise. So these are some of the differential diagnosis of subtotal villous atrophy. Now, what are the other investigation you like to do? Barium meal and follow through X-ray can be done, but this doesn't give us a lot of idea. Okay, so though theoretically written here, practically it is not done usually. If we do, it will show dilated loops of the bowel, and the contrast material is flocculated inside the bowel. Not a very important point. Sugar test of intestinal permeability are abnormal. Now, this is simply telling us that carbohydrate is not getting absorbed properly. And there is fat malabsorption as well, which we can detect by stool examination. The quantitative and qualitative assay of the fat on the stool, which can be done. This is known as steatorrhea. Now, the last part is the management. Remember the pathophysiology, then management will be very easy for you. So let me quickly give those important points again. This is an autoimmune disease, number one. Number two, if persons are taking gluten containing diet, then only signs and symptoms will arise. Number 2 point. Number 3, all of us will not develop celiac disease. Okay. Those people who are genetically predisposed will only develop celiac disease. So if you remember the 3 points, management will be very easy. And then what is the main problem here? Okay. Malabsorption and diarrhea. Because of this malabsorption, the person may suffer from malnutrition. Okay. Now let's go to the management. Once it is diagnosed or even suspected, lifelong gluten-free diet is given, or the patient should take gluten-free diet. Means they should exclude wheat, rye and barley as well as oat from the meal. These all are gluten containing diet. So let me underline them. See here, exclusion of wheat, rye, barley and oat. These are gluten containing diets, so we should not prescribe them to the patient, or we should tell them you should not eat them from now onwards. And we have got a good replacement. If these cannot be eaten, then replace them with rice, okay, corn or maize, as well as potatoes, which are a gluten-free diet. Okay, so good replacements are available. At the same time, correct the existing deficiencies of iron, folic acid, calcium or vitamin D, because many other micronutrients are also deficient because they are also not getting absorbed from the intestine. Because this is an autoimmune disease, okay, so we have to use corticosteroid or immunosuppressive drug, okay, to induce the remission in case of refractory sprue. First of all, you will advise gluten-free diet. If patient doesn't get better by gluten-free diet, then you need to go for the management with this medicine. Okay, these are corticosteroid and immunosuppressive drugs. Now let's talk about the prognosis. Okay, talk about the prognosis and complication of celiac disease. One of the complications I've already listed. This is called T-cell lymphoma, enteropathy associated T-cell lymphoma. And another malignancy may also arise there, which is called small bowel carcinoma. Apart from them, ulcerative jejunoileitis or even perforation can happen because of extensive inflammation, but these are a bit rare type of complication. Now, one other varieties of or manifestation, I should say, of celiac disease, which mainly affects our skin, is called dermatitis herpetiformis. Now, many students confuse this term with herpes virus infection because of the term herpetiformis, but actually there is no role of herpes virus infection in this condition. It is one of the manifestation of celiac disease on the skin. This is also caused by autoimmune mechanism. Now, why the term is given like that, herpetiformis? Because of the typical sign and symptom, like the lesion looks like a vesicle. Some rashes would be there, which is also caused by herpes virus. Probably that is the reason why it is known as dermatitis herpetiformis. Now, let's go to the topic. This is a chronic disease which is characterized by pruritic papulovesicle symmetrically distributed over extensor surface of our body. So mainly extensor surface are commonly affected. You see there, they are very pruritic, means itchy, and they are papulovesicles. Papule means solid nodule which are less than 5 millimeter in size, and vesicle means these are the small blisters which are again less than 5 millimeter in size. So this is the meaning, and they are mainly found in extensor surface of the body. Now, what do you mean by that? When a person stands in anatomical position, the back of the upper limb are called extensor surface, but frontal surface of the lower limb are called extensor surface. So please remember that. So back of the elbow, knee, front of the knee, or you can simply call knee, buttock, the whole back, and the posterior part of the scalp near the occipital area. All of these are extensor surface. So they may be having a lot of lesion. Almost all cases of dermatitis herpetiformis have gluten sensitive enteropathy, though it is subclinical. The frank malabsorption and diarrhea may not occur, but they are having some component of gluten sensitive enteropathy. That's why we call it is one of the part of celiac disease. Now look at these genes here, or genetic association. More than 90% of them express HLA-B8, HLA-DR3 and HLA-DQ3, same like celiac disease. And they can present at any age, but the most common age is between 20 to 40. Now see here, these are the different type of lesions in case of dermatitis herpetiformis. These are called papulovesicle, and many of them are already ruptured. See that the rupture already happened here, here also, but there is still one intact papule I can see, or vesicle. Papule means solid, vesicles is filled with fluid, remember that, and this is very itchy condition. Now, how to confirm the diagnosis of dermatitis herpetiformis? So some of the investigation which we do to confirm the diagnosis are: there is positive IgA anti-endomysial antibody, just like celiac disease, but here they have changed the name because skin is the target organ here. So these antibodies are known as epidermal transglutaminase antibody. Epidermal transglutaminase antibody, but they are IgA anti-endomysial antibody themselves. Sometimes they are also known as keratinocyte transglutaminase antibody. Now, if you take skin biopsy from the involved area, there are neutrophil rich infiltration which are present within the dermal papilla. Now, our skin is divided into two layers. The upper layer is epidermis, the lower layer is called dermis. In the dermis, there are dermal papilla present. or the superficial layer of the dermis is known as papillary dermis. Okay, so there a lot of neutrophils will be there. In late stage, there is a formation of bulla, and these bulla are present in the subepidermal region. This dermatitis herpetiformis is also classified under vesiculobullous disorders of the skin. So there are vesicle and bulla present, and many of them are present in the subepidermal region. So few are already ruptured before the patient comes to hospital, but many of them are still there because they are deeper. Okay, all of them cannot be ruptured. Immunofluorescence analysis or study show IgA deposition there, because look at the type of antibody here, IgA anti-endomysial antibody. That's why there is a deposition of granular IgA along with antigen. A small bowel biopsy can be taken to confirm whether there is celiac disease going on or not. And if we do that, there are features of villous atrophy seen, which suggest yes, celiac disease is there. Now look at this histopathology. Okay, this is histopathology. See here, look at this. This is the basement membrane. This is the basement membrane, and okay, this is epidermis. Epidermis has got many layers. The lowermost layer is called stratum basale, then stratum spinosum, then stratum granulosum, and the topmost layer is called stratum corneum. Now below than basement membrane there is a dermis. This is dermis area. Now, so what we studied just now, there is a formation of vesicle or bulla in the subepidermal region. This is the one. Okay, these are the vesicle or bulla, and the papillary part of the dermis is having a lot of inflammatory cells, mainly the neutrophils. These are the one. Now, how to manage this case? Okay, the most important management is advise the patient uh, to take gluten-free diet. They should never take gluten-containing diet again in their life. And if they strictly do this, okay, the disease is going to disappear. We can try dapsone in very severe cases. Okay, dapsone. This is an anti-leprotic drug. It can be tried. But at the end, there are some questions. Okay, please go.